Good afternoon, everybody. I'd like to welcome you to the Burnet Institute's World Hepatitis Day Symposium. Hep Can't Wait is the theme for this year. My name's Doyle and I'll be moderating the first half of our session today. Can I first start by acknowledging the traditional custodians of the lands on which we're variously meeting today. I'm on the lands of the Wurundjeri and Bunurong people and pay respects to elders past, present and emerging. We've got a packed program for everyone today. We're going to be talking about two broad themes, building successful partnerships for viral hepatitis elimination. And then we'll also pivot to looking at new horizons for elimination and what we need to do to get us to the end game. There's obviously a lot happening in this space and a lot of progress has been made over the last few years, but there's still many challenges that lie ahead. And our first presenter today is going to touch on the state strategies on how we're going to try and move forward. So I'd like to welcome the senior policy officer from the Department of Health Victoria, Elizabeth Birbilis, who will give us an update on the Victorian government's approach to viral hepatitis elimination. Elizabeth.
Good afternoon, everyone. I'd like to thank the Burnet for giving me the opportunity to speak to you all briefly today. I'll give you an update on our strategy achievements, the strategy renewal process, next steps, and touch on COVID-19 impacts. Next slide. So the Victorian Hepatitis B and C strategies 2016-2020 aim to address the significant public health burden from viral hepatitis and set the bold goal of eliminating Hep B and C by 2030 with ambitious targets. The Victorian Hepatitis B strategy was a first for Victoria, while the Hepatitis C strategy was the first since 2009 and since the introduction of DAAs for Hep C. The strategies reflect the government's commitment to decreasing the public health burden in Victoria, increasing testing and treatment, and eliminating stigma and discrimination. This was the first time that government articulated a policy pathway for the elimination of hepatitis B and C as public health concerns. The strategies also align with a range of strategies listed, as well as the national strategies. Next slide. Whilst there are too many achievements to name, a few worth mentioning are increasing access to Hep B vaccine for priority populations with a funding commitment in the 2017-18 state budget to expand the Hep B vaccination program. As a result of the great work across the health and community sector, community engagement, mobilisation and education, we've seen an increase in ordering of Hep B vaccine across all priority populations. Rollout of DAAs and multiple actions taken by people in this virtual room to dramatically increase uptake of Hep C treatment, such as EC Victoria and Australia, and all the associated innovative work. The training of primary healthcare providers in the management of viral Hep through the VITAL program. Between 2016 and 2021, the number of GPs who are accredited to prescribe S100 Hep B medicines has increased in Victoria from less than 10 to 62. What a fantastic collaborative effort. Next slide. So hepatitis B. So in terms of a progress update, during the life of the strategies, the number of Hep B notifications reduced by 28%. We know that COVID-19 impacted testing. But once the efforts of vaccination programs, both here and overseas, flow, cases are expected to continue to decrease. But we're unlikely to achieve a 90% reduction in new diagnosis by 2030 if we stay on the same trajectory. So what are the issues there? So getting more people tested for Hep B, either through primary care or community health, and getting people with Hep B treated, including adherence to annual monitoring of viral load. So for hepatitis C, in terms of progress update, the overall number of Hep C notifications decreased by 42% during the life of the strategies. As was the case for Hep B, we know that COVID-19 impacted testing. We now have antivirals with higher cure rates, and GPs are playing a greater role. Prescriptions for antivirals increased from 15% to 35% over this period in Australia, but we're unlikely to achieve a 90% reduction in new diagnosis if we stay on the same trajectory. We need to increase treatment, particularly in priority populations, which will decrease transmission and increase cure rate. Next slide. So given all of our suite of BBV STI strategies were expiring at the same time, consultations were held concurrently. 6 facilitated online workshops were held during September and October 2020, exploring the focus areas of prevention, testing and treatment and care. Almost 280 representatives from the sexual and reproductive health sector, funded agencies, clinicians, researchers, BBV STI service providers, Aboriginal community controlled health organisations, community and peer organisations attended the workshops. 111 responses were received through our website, and a big thank you to everyone who participated in the consultations, especially as they were during COVID-19 and online when people were juggling various responsibilities. Next slide. So what you told us, across all feedback that emerged, you told us that we needed to increase health promotion, education, awareness and literacy of viral Hep and harm minimisation behaviours, improve and increase testing in priority populations, including in non-traditional service settings, make use of innovation in testing technologies such as rapid point of care testing to improve priority population access, use innovative models of treatment and integrated patient management and care, strengthen partnerships and collaboration, advocate to the Commonwealth to reform Medicare benefits scheme and maintain and increase the use of telehealth and electronic prescribing, and ensure we address common system enablers such as surveillance systems, workforce development, stigma and discrimination. So the next steps, we produced a consultation summary, which was based on feedback and can be found on our Engage Victoria platform. We'll continue to work through comprehensive feedback and are finalising drafts of plans and look forward to the release of the new policy framework later this year. We will be working with members of the Victorian Departmental Advisory Committee for BBV STI to review and improve draft plans in August. We continue to ensure the best available data is used to inform our actions, including the mapping and modelling work undertaken by the modelling superheroes at the Burnet and Doyle Institutes. So in terms of COVID, while we were undertaking our strategy renewal process, COVID-19 was occurring. And whilst I mentioned leveraging COVID responses as a key theme in the consultation, it's also worth mentioning the impact it had on viral hepatitis. So BBV and STI prevention, testing and treatment services were defined as essential services and maintained during COVID-19 pandemic lockdown restrictions. But interruption and deferral of testing and treatment for viral Hep and more broadly for BBVs and STIs could have a significant public health impact for individuals in the community. The Doyle Institute released a report in April 2021 detailing the impacts of COVID-19 on BBV STI testing, care and treatment using Medicare data. And the data shows that there have been substantial decreases in Hep screening and monitoring and hepatitis C treatment during the pandemic. Some increases have been seen after initial declines, but rates remain below 2019 levels. Encouraging patients who have deferred or interrupted their Hep B care to re-engage with treatment and screening services is now a priority, and Hep C. In keeping with the World Hep Day theme for 2021, Hep can't wait. We need to continue to ensure that priority populations are screened, tested and have access to treatment if required and engaged in care. We must also continue to promote vaccination in all priority and eligible populations. This is the message that Minister Foley is encouraging for World Hep Day this year through the department's various social media platforms. To achieve the elimination of viral hepatitis in Victoria as a public health concern by 2030 and reduce stigma and discrimination associated with the disease, it is essential that members of the community, government and health and community services work together and collaborate. There is still so much we can do collectively. I thank you for the amazing partnership response that is nationally recognised. I look forward to working with you to implement priorities in the 2021-2025 Victorian Hepatitis B and C plans.
Thanks very much, Elizabeth. Fantastic to hear from you and the commitment from the state government. It's really a critical partnership in this approach. We're going to move to the first of our two theme sessions now, where we're going to talk about building successful partnerships to achieve elimination. You're going to hear from 6 presenters in rapid fire, and then we'll have a short moderated discussion at the end. So I'd encourage anybody with comments to please pop them in the Q&A window, which is at the bottom of your Zoom screen. We'll try to get through as many questions as we can in the short discussion, or group them together to get the themes represented in the discussion. So you can put the Q&A questions in as we go through each talk, but we'll save responding to them until the end. So can I welcome the first presenter in this section? Dr. Alisa Pedrana is one of my good colleagues and friends, and she's the Eliminate C Partnership in Victoria coordinator and also the National EC Australia Partnership coordinator. She's a senior research fellow at Monash Uni and is going to tell us about the successes of the partnership so far. Thanks, Alisa.
Thank you, Joe, and welcome everybody. It's my honour and privilege to be able to present some key highlights from the EC Victoria partnership. And I'd like to acknowledge that I'm on Wurundjeri country and pay my respects to elders past, present and emerging. So for those that aren't aware of the EC Victoria partnership, it's been a project that's actually been ongoing for the last 5 years, originally funded in 2016 through a partnership grant with support from Gilead Sciences and the NHMRC. It aimed to increase access to hepatitis C testing and treatment among people who inject drugs in order to meet the WHO elimination targets. And with a bit of fancy modelling, we were able to put forward an estimate number for the numbers of people we expected that needed treatment for us to have impact on both prevalence and incidence declines over that time. And that's that number, 1,160 per year for 5 years. Now, at the start, we aimed to establish a community treatment program that both focused on improving access to hepatitis C testing and treatment, both in primary care and in the prison system. And our approach was one that tried to cover a health system strengthening approach. So we had one component focusing on increasing demand through health promotion, component that focused on increasing clinical capacity through training and education and increasing access to testing and treatment by providing clinical support through nurse-led models. And these were both implemented in the community and also in the prison settings. We then aimed to establish an integrated hepatitis C data and surveillance systems to allow us to monitor trends in both testing and treatment, as well as prevalence and incidence over time. And finally, we aim to trial new interventions that hope to increase uptake of testing and treatment. And for us to assess then the feasibility of that initial aim of testing and treating 1,160 people with inject drugs for 5 years consecutively. Next slide, Liz. So for the next few minutes, I'd like to just highlight a few different ways in which the EC Victoria partnership really aimed to work in partnership with both community, clinical and government partners and implement a few key activities that we feel deserve some highlighting. So for health promotion, we funded a number of community partners to develop health promotion resources specifically targeting people who inject drugs. We also convened a health promotion working group, and this was led by Judy Gold, who coordinated regular meetings to share information and lessons across the group. She coordinated specific workshops aimed at improving health literacy of client resources and developed a catalogue of existing health promotion resources that has been made available across Victoria. Within the training and education area, we partnered very closely with Vital, the primary healthcare networks, and ASHM to deliver a number of different training courses to nursing and also AOD sector workforce, and also provided direct one-on-one mentoring to specific providers within our EC sites. We developed a FibroScan training and certification program, and we've provided 2 mobile FibroScans within the regional areas for the integrated hepatitis C nurses across Ballarat, Bendigo, Goulburn Valley and Barwon Health to have access to. And it's also been loaned down to our Tasmanian counterparts in the south. Next slide, Liz. Our clinical support team, which has really been driven by our EC nurses. So I'd like to acknowledge the tremendous work of Chloe Layton, Kiko Chan and Lisa Arcadia in really informing what we implemented in partnership with many different primary healthcare services. So the EC nursing model is what we called it, was initially developed from some scoping exercises where we spoke to different clinicians, identified some of the critical issues that were coming up in delivering hepatitis C care. And then we developed an EC practice support toolkit, which many of you hopefully will have seen or been involved in developing. And this was then utilised to provide direct services within EC sites. Fantastically, the primary support toolkit has actually then been supported through the EC Australia partnership to go nationally, and Chloe Leighton and Jackie Richmond have, in partnership with different jurisdictional partners, developed an EC primary practice support toolkit for every single jurisdiction across Australia. We've disseminated 620 copies to date. The statewide prison program has been led by St Vincent's Hospital Melbourne, and I won't talk to it too much as Alex will be covering quite a lot of these activities in the next session. Next slide, please. But I would also like to acknowledge the tremendous work of Rebecca Winter in coordinating some of the data that's come out of the statewide prison program, and acknowledge the nursing team at the SHP team who have done a tremendous amount of work, both linking the 14 different prisons and delivering hepatitis C treatment across that sector. Within data surveillance and systems, we expanded the access surveillance system across 16 primary healthcare sites and developed indicators to monitor hepatitis C care cascades at a service level. And I'd like to acknowledge the work of Michael Traeger and Anna Wilkinson in this area, and particularly a huge thank you to our access team who have worked very closely with our EC nurses to ensure we've been able to deliver site reports back to services for them to understand how they're tracking over the last 5 years. And I think some of the areas where we've had greatest success in partnership models has really been around the research and evaluation components, where we've delivered a number of different pilot or demonstration projects that have responded to different challenges we've identified across the 5 years. Given so much has changed within the sector in the last 5 years, both back in 2016, what was available, then in response to COVID, and now we're in an era where COVID must be part of our hepatitis C treatment plans, that we're really lucky that we've got such great partnerships across both primary care, community, and with government to deliver many of these different service interventions. Next slide. When we look at what some of the ongoing activities are likely to be for the next 6 months, we'll be focusing on transitioning and closing out some of the key projects that I mentioned, completing an evaluation of the EC partnership. And I've identified a few of the key evaluation questions here. And also we will maintain our EC newsletter for the next 6 months so that people can have access to up-to-date information, and consider how we transition some of these activities across to various different community or partner organisations. And finally, my last slide, Liz, thank you. Next slide. I'd like to just acknowledge the tremendous work that has gone into achieving some of these key outcomes. So we've supported 11 primary care services to test almost 5,000 people and treat over 1,000 people who inject drugs, and supported 14 prisons to assess 2,000 and treat almost 2,000 people within the prison sector. We plan to bring together a lot of the evaluation outcomes in a knowledge summit in early 2022, and continue to leverage all the further funding opportunities that we have available to ensure that we can sustain our activities and sustain the impact that we've had to date. So thanks very much, Joe, and for the invitation to present, and for all the key partners and people that have contributed to the EC Victoria partnership. I look forward to hearing from the next round of speakers. Thanks.
Thanks very much, Alisa. What a fantastic effort from you, your colleagues, and all your partners. Can I move on now to Dr. Dan O'Keefe? He's a Senior Project Officer at Burnet Institute, and he is going to start this discussion about partnering with clinical services and give us a bit of insight into research into practice. Take it away, Dan.
Can we just go back one slide? Thanks for that. So thanks for that, Joe, and happy World Hepatitis Day, everyone. I'm just talking very briefly around that kind of research into practice, but specifically the partnerships that Burnet has with its clinical and community partners, and along with Thatcher, talking about the mutual benefits that both the research organisation, being Burnet, and the partners get out of these partnerships. Next slide. And when we are talking about these partnerships, we're quite often talking about really historic and enduring research partnerships, and using Access Health as the example. The Burnet has partnered with Access Health on various projects for well over 10 years on many, many different kinds of projects, including sort of data collection projects. Access Health was one of the original recruitment sites for the Supermix project, which is Australia's largest ongoing cohort of people who inject drugs, and is also one of the annual surveillance sites for the illicit drug reporting system, the government's drug trends monitoring system, but also many, many other kind of small and large implementation studies, particularly those within within EC Victoria. And those research partnerships kind of bring up many different mutual benefits, and always practicing COVID safe measures, of course. So next slide, thanks. And what are the benefits to the Burnet as the research organisation? So working with a community partner like Access Health, we're talking about like a research supportive environment. Access Health really knows what the Burnet needs and how it provides it when we're talking about a research project. And it really allows our projects to kind of hit the ground running. Obviously, we're talking about having existing participant groups, which really facilitate the recruitment of our participant samples. And we're talking about known and trusted project partners, people that kind of known quantity element, and partners who really know what we need and how to provide it. And particularly having that on the ground experience that we can leverage, that really helps not just the implementation of a project, but also the development of a project, so that the Burnet can really liaise and consult and really build up and develop the project prior to its implementation. But then also particularly help us to kind of fix any problems that may be cropping up during the implementation phase. And then thinking about some of the kind of ancillary benefits that come along with it, things like referral of services. We may have participants who need kind of additional services beyond just the research project itself, particularly relevant to things like Hep C testing and treatment, that a research assistant may then be able to refer the participant onto. Next slide, thanks. And then just to talk very briefly, just about a couple of projects that we currently have in partnership with Access Health, but this is just a small sample. We have the Experience cohort, which is a prospective cohort of people who inject drugs, and is looking at changes in Hep C testing and treatment engagement over time, and also the path expanded evaluation, which Jane and Caro are talking about just next. But this is a partnership that looks at partnering peers and nurses to enhance Hep C testing and treatment. But suffice it to say that these projects wouldn't be what they are, and probably wouldn't be able to be without the existing partnerships that we have. And that's it for me. I'm throwing over to Beck now.
So thanks for the tag team. Let me just quickly introduce Rebecca Thatcher, who is the Program Manager of the AOD and Harm Reduction Services at Access Health and the Salvation Army Crisis Centre. Welcome, Beck. Please jump in and continue on with that fantastic discussion.
Thank you so much, Joseph, and thank you, Dan, as well. Yes, I thought I would just give a really quick rundown of the services that we provide in St Kilda, but also right across Metro Melbourne now. We run primary healthcare services. It's called Access Health, targeting people who are experiencing homelessness, people who are seeking help related to drug use, primarily by injection, people who street sex work, and also people, experiencing barriers or marginalisation to access to AOD and healthcare. We also run a 24/7 primary needle and syringe program, so that it always has a person on site offering harm reduction advice, referral, overdose education, access to naloxone, and a whole range of activities there. And more recently, originally in response to a hepatitis outbreak in Metro Melbourne at the start of last year, we now operate the mobile immunisation health and harm reduction service in partnership with St Vincent's Hospital and also the Burnet Institute. I've tried to pop up there as well all of our practice partnerships. So we're a one-stop shop sort of hub model of service provision to try to provide as much as we can in an opportunistic sort of way to this cohort. Next slide, please. So as Dan mentioned, we've been involved in a lot of the research with Burnet Institute for quite a long time. I couldn't remember when we started, but I put in early 2000s. I've just listed there a whole range of the research partnerships we have currently, with a lot of them continuing on now. I won't go through them all because you can read them just there, but we'll go to the next slide, please. So the benefits to us for having this partnership with a research provider, and especially in regards to Hep C, are vast. There's a lot of benefit to us. To begin with, one of the major benefits is improved service access and, I guess, good service provision to the people that we're trying to target. We know that barriers to access and barriers to accessing specialist services and mainstream health services exist. And so when we have these partnerships, especially in regards to research that is service provision focused, it really enhances access there and outcomes for people accessing the service. We have improved clinician knowledge and skill set. So we have direct access to clinical nurses and to specialists, infectious diseases clinicians, and a whole range of other people, researchers that we're able to get information from, and we're able to upskill ourselves around Hep C. We're able to learn more about the people that we're servicing. So we can learn more about their characteristics, their needs, the trends within the cohorts. Obviously, we have improved patient outcomes as a result of all of these increased collaborations through these research partnerships. We have formal partnerships currently with Harm Reduction Victoria, Alfred Health, Burnet, Bolton Clark Homeless Persons Program, St Vincent's Health Melbourne, Hepatitis Victoria. So a whole range of formal partnerships, and then there's all of these informal partnerships. So it's much better collaborative practice as well. And we just have a stronger service and a stronger health system as a result of it. Next, please. So for us, there's also a whole range of on-the-ground, really practical things that these partnerships have resulted in. So better CQI and clinical audits, better client pathways and systems, clinical systems. We're reduced stigma because we have more accountable and conscious clinicians when we're working, for some of our projects in the peer space. We're able to have more support to run campaigns, to run Hep C incentives campaigns that we continue to do every year. Our referrals have increased between a whole range of services within the sector. And more importantly, we have those really good, strong relationships when we need them as a service to do things like evaluation, which we did recently and helped us to secure our funding ongoing. So that's me. Thank you, Joseph.
Thanks so much, Beck. Our next speaker, we'll move on just in the interest of time, is Sione Crawford, who's the CEO of Harm Reduction Victoria. Sione will be followed by Caro Weidner, who's a peer specialist at Harm Reduction. They're both going to talk to us about the PATH project, which uses peers and nurses in practice together. Sione, can you take us through the PATH project and what we've learned?
Sure thing, and I won't take up too much of your time. Unfortunately, originally Jane was going to do this presentation, so these are her slides. So I'll probably, what I say may or may not relate directly to the slides. I'm going to talk a little bit about the PATH project, which is a partnership between Burnet, Harm Reduction Victoria, Access Health, Co-Health, and Integrated Hepatitis nurses. And I'm just going to give a little bit of framing about what peer work is and what PATH is. So PATH is our peer navigation program, which has a number of peer specialists. This year we're undertaking PATH X, or PATH Expanded, as Doc and Beck pointed out. Ultimately, what it comes down to is peer workers are people who are able to share a lived and living experience with the people that they're working with. And in this context, obviously, hepatitis C is an important component, but so too is injecting drug use. And one of the reasons that's really important is that, as you guys probably all know, there aren't very many settings in which being completely honest about illicit drug use is a positive experience. And so we work really hard as peer workers to ensure that people are able to be honest with us so that we can work with them to overcome some of the barriers. Next slide, please. And ultimately, good peer work really works because as people who use drugs, we tend to learn from our community, and we tend to trust people who have been through similar things or have had similar experiences to us, and we're familiar with the motivations, issues, and concerns of our community as peer workers. Next slide, thanks. Having said that, the reason that peer work is really important is because it's still the case that accessing Hep C treatment is more complex than it needs to be. I think we're getting, as Jane has tried to point out with the slide, I think it's pretty clear that we're getting better and better at providing Hep C treatment to our marginalised community, but there is still, as she's pointed out with this slide, you know, the old cascade of care had multiple places for people to fall through the gaps. And we're improving that by incorporating peer work and peer educators and bringing in far more simplified testing and treatment options. I'm going to hand over to Caro now to talk a little bit more interestingly about what it is to be a peer specialist, and for her to go through some of her day-to-day work with you.
Thanks, Sione. Welcome, Caro. I feel like I'm just handballing from Sione through the computer, and back to you, Caro.
Thanks, Joe. Gee, I hope the expectations aren't too high, Sione. You've worded me up there. Anyway, hi. Thank you very much for asking me along to speak today. My name's Caro, and I'm going to talk today about what it's like to be a PATH peer worker working at a mainstream service in the inner suburbs of Melbourne, trying to increase uptake of Hep C treatment among people who use drugs, who inject drugs. In line with the Victorian government's aim to eradicate Hep C by the year 2026, our co-designed PATH pilot project arose out of a need to find ways of engaging with our hard-to-reach population. Next slide, please. Being a peer means we come from their community. We have some of the same issues and concerns, some of the same experiences, particularly around stigma and discrimination when accessing health services. So what do we do on an average day? How do we go about engaging with clients? Why are we there? What works and what doesn't work? The PATH pilot was based at Access Health in St Kilda, and our first week kicked off during World Hep Day in 2019. Access Health was having a week-long barbecue with Hep C testing and treatment campaign running alongside, offering $10 incentive gift card when punters have a test. And then they were getting another gift card when they came back for results. And then when they came to get their script for treatment, that was probably the same appointment. And then another incentive when they came back to get the hopefully cleared virus results, and then clear the virus. Working with the chronic diseases care coordinators proved a great match because Lauren and Jazz were already working with some hepatitis C clients. Currently, under PathX, Jasmine is one of the chronic care team, has become the PATH coordinator and is working closely with Stu, our PATH peer over at Access Health now under PathX. The expanded project has meant we could employ 2 near-peer specialists from Harm Reduction Victoria, Stu, who I just mentioned, and Sammy, who works at 2 other services under a roving model, Co-Health in the West and Youth Projects in the CBD. So thinking back to World Hep Day in 2019, there was the opportunity to talk to numerous clients that week because of the barbecue, and it meant I could test out my cold engagement skills, which was a big part of the job. I was working alongside Rob Lederman, who's since left HR Vic. But it's a big part of being a peer, is being able, well, PATH peer, is being able to engage people cold. And you have to be able to find common ground quickly. And it's rare that the first thing people want to talk about is their Hep C status. Most of the time, people who inject drugs running a chaotic lifestyle, trying to find enough money to score, avoiding the police, getting around during a pandemic lockdown when your dealer lives more than 5 kilometres from your house, etc. Next slide, please. One main challenge of the pilot was that we didn't have a dedicated nurse for most of the project. Access Health did have one at the start, but he left very early on and wasn't replaced until the beginning of 2020. Then the pandemic hit. So we didn't get to work on site at Access Health for the rest of the pilot project. There's actually been a noticeable difference with PathX in that we've had a dedicated hepatitis C nurse on site, Sandra, with our PATH peers, and we've got Sally over in the west with Sammy. And in the first few weeks of the new project, there were several engagements with punters that led to a Hep C test. Those people's results all came back negative, so we haven't yet started anybody on treatment, but these things take time, as we all know. Sammy continues to establish and build relationships with workers and punters in the West, and Stu's making inroads over at Access Health, like I said, with several engagements and more to come, I'm sure. Continuous lockdowns make it difficult for our peers and their services, and they're doing their best to work around that. Hep C may not be able to wait, but patience and hard work will hopefully lead to Sammy and Stu guiding people from our community into treatment and walking beside them through their entire journey. Thank you.
Thanks so much, Caro, and thanks again to Sione for presenting that peer perspective. It's really valuable and really great to hear from you. The final speaker in this session, and just a quick reminder, please pop any questions, any topics you'd like us to come to after this final speaker. You can do that in the Q&A session. And Professor Alex Thompson will now take us through some of his work and his team's work at the the medical supervised injecting room and expanding the statewide hepatitis program in the prison service. Alex.
Thanks very much, Joe, and thanks for the invitation to speak today. World Hepatitis Day is an important anniversary, and it's just terrific that the Burnet have put on this symposium. Now, Joe has already warned me that I have too many slides and I need to speak quickly. So Liz, next slide, please. Next slide, please. So I'm going to be talking about some work that we've been doing focused on engaging people who inject drugs in hepatitis C testing and treatment. As Joe said, our work in a high prevalence community clinic, the safe injecting room, and also our work in the justice health sector. Next slide, please. So the first piece of work I'd like to talk about was a pilot research program we performed asking the question of, can we utilise hepatitis C point of care technology to create a simplified, streamlined model of care that improves screening rates and allows rapid treatment initiation within the context of the Melbourne Safe Injecting Room in Richmond. So the Safe Injecting facility sees more than 100, oversees more than 100 client visits per day, and there have been more than 5,000 registered clients since 2018. Next slide, please. Most of the audience will be familiar with the recent TGA approval of the GenExpert hepatitis C viral load fingerstick test. This is a point of care test that provides a hepatitis C RNA result within 45 to 60 minutes. Next slide, please. This slide briefly describes the point of care testing program. Clients were approached as they registered at reception at the safe injecting room. They had the point of care test performed before moving through the centre into the injecting room. They were followed up in the recovery room, known as Zone 3, where a FibroScan was performed, a questionnaire was delivered, and then for some clients with the availability of their hepatitis C RNA result, the team worked to facilitate same-day treatment for their hepatitis C. Next slide, please. So to take you through the results, in a 9-week period at the end of last year, 228 people consented to testing. This represented a 274% increase using the point of care test compared to the standard of care within the same time period 2 years prior, pre to COVID. I think it's important and relevant for this population to note that 91% of the patients who had a serology test as part of this program were antibody positive, drawing into question the clinical utility of antibody testing in a high prevalence cohort. There were 28% or 27 individuals who were hepatitis C RNA positive. I think there were 61 individuals who tested RNA positive. There's an error with the advancing of this slide, representing 28% of the cohort tested. Of the 64 people who tested positive for hepatitis C, 61 or 95% were able to be provided with their test result, and 40 or 67% of the cohort received their result on the same day as the test. And of the 61 who were notified of their positive result, 56 or 92% were started on DEA therapy, and 20% were started on treatment on the same day as testing. Next slide, please. So in conclusion, point of care testing rapidly engages large numbers of people who inject drugs in hepatitis C screening in a high volume supervised injecting facility. High rates of hepatitis C RNA positivity were seen, and screening with antibodies appeared to have a limited role in this context. Almost all of the Hep C RNA positive clients were successfully linked to treatment. And I think, I reflect that dedicated hepatitis C staff were critical for this linkage to care. And we hypothesise that the early delivery of results and the rapid treatment initiation may have been important factors improving the care cascade for these clients. Next slide, please. And then finally, I'd like to acknowledge the Department of Health, who, based on these interim results, have funded an extension to this point of care testing program. In contrast to the pilot program, where a medical fellow led the research program, the next phase of this project will involve testing led by a harm reduction worker, working with hepatitis nurse specialists to facilitate assessment and linkage to treatment for hepatitis C positive clients. Next slide, please. I'm now going to move on to talk briefly about our work in the justice system. Next slide, please. So many of you will be familiar with the statewide hepatitis program in Victorian prisons led by Anne Craigie, Lucy McDonald and Amy Edwards. This is a nurse-led model of care where the nurses take the care to each of the prisons in the state to perform on-site assessments and facilitate locally based prison treatment. Treatment of hepatitis C in the prison sector is very effective, just as effective as in community registration studies, as was seen in our early experience led by Tim Papaluka, where a per protocol cure rate of 96% was seen in the prison. Next slide, please. Michael McIsaac presented an update last year at the Australian Gastroenterology Week, our experience from when the program started in early 2016 to the end of 2019. At this point, more than 3,400 assessments had been performed and more than 2,300 individuals had commenced DAA treatment. Just advance the slide, please. And I'm proud to say that as of this year, more than 3,000 treatments have been delivered. If you can advance the slide, please. I include this slide to make the point that prisons are now the most common setting for hepatitis C treatment initiation in Victoria, with now 18% of the total treatments in Victoria to the end of 2019 occurring within the prison sector. And advance the slide, please. And in last year, more than 20% of treatments in Victoria were delivered through the prison sector. Next slide, please. What about post-release? There are some prisoners who, despite being diagnosed with hepatitis C in the prison sector, cannot be started on treatment due to imminent release to community. Tim Papaluka, a PhD fellow and gastroenterologist at St Vincent's, performed a randomised control trial and demonstrated convincingly that care navigation can increase treatment uptake in the community after release from prison. So these are the primary results from his study, showing that 73% of former prisoners released to community can be linked to treatment within 6 months of prison release, compared to 33% with the normal standard of care. And care navigation also dramatically reduces the time to DAA treatment. Next slide, please. So future opportunities for the prison sector. I believe there are opportunities around optimising screening rates. I think it's an exciting opportunity to explore point of care testing at reception, at prison reception. I think opt-out screening is something we should be starting to have a conversation about, as well as defining key performance indicators for prisoner screening rates. And I would propose a screening rate of at least 75%. I think there are opportunities for care beyond the walls of the prisons. So we've discussed the linkage to care post-release to community. And I'm also pleased to say that the CLINC study, which was our Care Navigator linkage project, has been supported again by the Department of Health as a pilot program to extend this. The community corrections population in Victoria, this refers to people who are on parole but not actually in prison, is actually a larger population than the prison population. And I think this is a great opportunity to explore how we can start to engage clinically. And then it is always important to note that there are opportunities to improve harm reduction strategies within prisons in Australia. Next slide, please. So to conclude, the key challenge for Australia in achieving hepatitis C elimination is to increase testing and treatment amongst people who inject drugs. High prevalence services have a key role to play in the public health response to eliminating hepatitis C in Australia, both in the community and in the prisons. And point of care testing is an exciting technology that's now approved in Australia, and it has the potential to improve the cascade of care for people living with hepatitis C. I might finish there. Thank you.
Alex, thanks very much. And thank you so much for keeping to time. Can I thank all of the speakers in the session that we've just gone through? Alisa, Dan, Beck, Sione, Caro, and Alex. Whilst there are a few questions in the chat, or some themes in the chat that we're going to pick up on, Alisa Pedrana is now going to take over moderating for the next session, and she and I have decided that we think that we'll park some of these questions and themes till the end, so we keep on time mostly, and we'll raise some of these discussion points toward the end of the symposium if we can now. So Alisa, can I hand over to you to take us through the next theme?
Absolutely. Thanks, Joe. And thanks, Alex, for that great presentation. So the next session is really sort of looking forward in time. The last session was focused on what we've learnt, some of the partnerships that we've built, and a lot of the different ways in which we will continue to stay motivated and enthusiastic about hepatitis C and hepatitis B elimination. And for the next session, we'll really be inviting key speakers to talk about their sort of next steps and key activities on the horizon. So first speaker is Prabal from Hepatitis Victoria LiverWell, who'll be talking to us about innovations in workforce training. Welcome, Pearl.
Thank you so much, Alisa. I'm just having some trouble turning the video on.
There we go. I can see.
Yep. Good afternoon, everyone. I would like to thank the Burnet Institute for the opportunity to share our work. Today, I'll be talking about our Hep-Ready programs. And to dive right in, I'll start talking about the concept behind the development of Hep-Ready and how it contributes to the elimination of hepatitis. So to meet our elimination targets, we need to address gaps in hepatitis care. And our healthcare workers play a crucial role in addressing this gap in care. That is helping increase rates of testing, diagnosis, and treatment uptake. Workforce training programs are vital for developing and expanding this knowledge and building a confident healthcare workforce, decreasing stigma, as well as facilitating respectful communication with people at risk of hepatitis or those with hepatitis. Next slide, please. So Hep-Ready is LiverWell's suite of training courses for community and healthcare workers. It aims to build knowledge about and take fear away from viral hepatitis. Through this program, the key goal is to raise awareness, empower the workforce, and encourage a systematic change in the way the Victorian health workforce diagnoses, treats, and works with people with viral hepatitis. So our main offering from Hep-Ready is the Hep-Ready Essentials course that's offered monthly, accredited by the Australian Primary Healthcare Nurses Association. We also have a range of diverse other offerings that have been outlined in this slide. Next slide, please. In terms of innovating for workforce training, I'd like to begin by talking about our online learning portal. So our online learning portal offers a great deal of flexibility. It allows our participants self-paced learning and access to our digital tools and resources. Coming to our lived experience speakers, they're a key draw for our audiences for all our trainings. They offer great personal insights into their journeys through diagnosis and treatment, and they raise awareness about challenges and stigmas faced along their journeys. In terms of adapting Hep-Ready offerings, last year we transitioned to online learning fairly quickly as lockdowns and restrictions were announced. New content was added as part of embracing our broader liver health remit and addressing concerns around contracting coronavirus and vaccination, questions regarding eligibility for vaccination for people living with viral hepatitis and liver disease. We received a number of queries on our LiverLine and web chat information services regarding the same. I'd also like to mention that some service sectors like the AOD sector reported increased service demands during the pandemic. Therefore, it was important to continue educating the workforce to help them cope with increased service demands. Coming to evaluation and reporting, it's important for us to keep track of our course outcomes, incorporate the feedback we receive from our participants, and gauge impact from our courses through regular evaluation. And lastly, the HEP Ready program was set up as a social enterprise to expand workforce learning and to reinvest the income made back into its ongoing development to ensure that we can keep delivering workforce learning and making a positive impact. Next slide, please. So this provides a snapshot of participation in our HEP Ready programs in the past 12 months. So we deliver to a wide range of service sectors and about approximately 372 participants from 90 different organizations. In terms of sector-based participation, maximum participation was seen from the community health services and the AOD service sectors. And in terms of location-based participation, we had maximum participation from organizations in metropolitan Victoria, followed by regional Victoria and some interstate and international organizations. Next slide, please. Coming to program impact and summarizing my presentation, data from our pre and post evaluation surveys indicated a significant increase in knowledge, intentions to act, and incorporating these learnings into everyday practice. Changes in attitudes were noted post-training from our evaluation data, and it showed that attendees did not hold stigmatizing attitudes towards people with viral hepatitis. And this was attributed mainly due to better understanding of the transmission routes for viral hepatitis. And lastly, 98.15% said that they would recommend HEP Ready training to others. That's it for me. Over to you, Alisa.
Thank you very much, Pearl. And we'll leave questions till the end of the session. And the next speaker, I'd like to invite Freya Saich, who's our lead policy officer within the EC Australia program, who will be talking to us about developing a viral hepatitis advocacy strategy. Thank you, Freya.
Thanks, Alisa. Next slide. So just for a bit of overview in terms of EC Australia, it's funded by the Paul Ramsay Foundation and coordinated by the Burnet Institute, and is a partnership that brings together a range of organisations and stakeholders around a common goal to eliminate hepatitis C as a public health threat by 2030. And we aim to achieve this using combined efforts across 5 key areas, including workforce development, health service delivery, a health promotion campaign, implementation research, evaluation and surveillance, and an Aboriginal and Torres Strait Islander health strategy. And I guess across all of those sort of domains, there are a sort of number of issues, particularly within the policy space, that are impacting on Hep C elimination. So if we just move to the next slide, I'll just show you the process, I guess, that we've gone through in terms of developing an advocacy strategy and sort of how we've got here today, and then sort of the next steps. So before I sort of joined the Burnet Institute, EC Australia conducted national consultations in each state and territory, looking at sort of the key issues. And from there, when I joined, I conducted a policy mapping exercise, looking at all of those issues and some of the advocacy efforts that had happened previously, and sort of what the policy environment was looking at. And from there, we identified well over sort of 60 different issues, and sort of needed some way, I guess, of prioritizing that and finding policy issues that our sort of key stakeholders sort of all had in common. And so we formed a working group involving ASHM, ABLE and Hepatitis Australia, and they were incredibly invaluable in advising us on that process that we needed to go through. And from there, we developed a 2-stage policy prioritization exercise. The first stage was with internal stakeholders, Burnet Institute, looking at sort of the feasibility of these policy issues, the policy window, and sort of likelihood of change. And then from there, we took those sort of top issues into a second stage involving our EC Australia Advisory Committee to then agree on our policy priorities. And from there, we've got these sort of next two phases that we'll be working through in terms of developing and implementing an action plan until sort of the end of 2022, which is when we're funded until, and also looking at how we can support the work of our stakeholders to continue to advocate post ECA. Next slide, thanks. So I guess just as a quick overview in terms of the range of policy issues that have come up, and I'm sure many people here are very well aware of these, they sort of expand from prevention, testing, liver cancer surveillance, addressing stigma and discrimination, valuation surveillance, and some sort of broader health system and sort of non-health areas where people with hepatitis C also stand to benefit, as well as a range of other stakeholders. Next slide, thanks. So the sort of policy priorities that we sort of landed on with the advisory committee were around these three key areas of improving hepatitis C testing, including expanding the use of point of care tests. And that involves also looking at reflexive testing, funding point of care tests to be used in a range of settings, and also looking at other opportunities around dried blood spot testing. The second is around increasing support for peer workers across the care cascade, including in mainstream settings, and also in their work to do outreach and hepatitis C testing. And that's where the DBS would be really valuable there. And then lastly, in terms of enhancing hepatitis C testing and treatment within prisons through the use of national standards and key performance indicators. So from here, we'll sort of be working, as I said, through some sort of action plans to begin this advocacy work, and also joining up with those already doing advocacy in this space, and really keen to hear from other stakeholders. So please get in touch if we don't already reach out to you. And also if anyone would like any further information about how we sort of did that process and whether that would be useful to other organisations, we're very happy to share that information. Thank you.
Thank you, Freya. What an immense amount of work, and presented so simply. Obviously, the hard work starts here in terms of trying to build those coalitions to enact change. But congratulations on such a fantastic, comprehensive view of some of those policy challenges. The next panelists are a combo. So I'd like to welcome Dr. Jess Howell, who's a gastroenterologist at St. Vincent's Hospital, Melbourne, and also a senior research fellow at Burnet Institute, and who will be followed by Dr. Jack Wallace, who is a senior research officer at the Burnet Viral Hepatitis Group. Over to you, Jess. Thank you.
Thanks, Alisa. And it's a privilege to speak today about overcoming barriers in hepatitis B, preparing but not waiting for cure. Next slide, please. The global burden of hepatitis B is vast, and it disproportionately affects the Asia-Pacific region, which is our region. In order to address the deaths from hepatitis B worldwide, the WHO has set 2030 elimination targets. The impact targets are to reduce new infections by 90% and to reduce deaths by 65%. And in order to achieve these, we need to diagnose 90% of people, they need to be linked to care, and we need at least 80% of those eligible for treatment on treatment. If we don't achieve these 2030 targets, modelling suggests that 63 million avoidable new infections and 17 million preventable deaths will occur due to hepatitis B by 2030. Next slide, please. Now, how are we tracking towards these goals in Australia? Well, we have made some progress, but we have a long way to go, with data from the mapping project showing that of the estimated 226,000 people living with hepatitis B in Australia, only around 2/3 of them are diagnosed, 22% are linked to care, and less than half that are eligible for treatment are on treatment. Next slide, please. And why are we getting it wrong? Well, there are multiple barriers to hepatitis B testing and linkage to care experienced by people living with hepatitis B and the health workforce. From the perspective of people living with hepatitis B, there's significant stigma and discrimination around hepatitis B, lack of awareness and therefore lack of demand for testing and treatment, and multiple experienced healthcare access barriers. Hepatitis B is also a chronic disease experienced in different ways across the lifespan, requiring retention in care, which is a major challenge. From the perspective of health workers, there's lack of awareness, extremely complex guidelines in terms of who to treat, lack of support to do so, and competing priorities, particularly in primary care, and service delivery barriers. Next slide, please. Now, around the world right now, there's a multitude of excellent projects underway by various groups that we collaborate with, doing wonderful work around novel models of care for hepatitis B, including task shifting to nurse-led models of care, community engagement and outreach. Next slide, please. However, what I would like to pose is that there's some big questions we all need to address and think about when we're approaching hepatitis B elimination in Australia. Some of these include, how do we increase demand for hepatitis B testing? How can we effectively get around the stigma and discrimination that people face and increase their demand for hepatitis B services and diagnosis? When, who, and how should we treat hepatitis B? We have excellent guidelines which are very good at preventing deaths from liver cirrhosis and very good at reducing the risk of liver cancer. But even when guidelines are followed, 1 to 2 out of every 100 people living with hepatitis B will still develop liver cancer and at risk of death from liver cancer. How do people living with hepatitis B want to manage their disease? Would they like more choices about how we approach treatment? Would they like to be involved more actively in self-managing and self-monitoring their disease? And finally, what do we really mean by cure when you hear this mentioned? Are we talking about something for patients and people living with hepatitis B that means removing hepatitis B completely as a concern and worry for them in their lives? Or are we talking about something in a more clinical problem that needs to be addressed with medication? And I'll now hand over to Jack Wallace, who's going to take up this last point in particular.
Thanks, Jess. Next slide. Beautiful. Go back a slide. Thanks, Liz. We've just started a project to identify issues affecting the implementation of a Hep B cure. Let's be clear that the cure isn't anywhere near ready, but there has been significant and continuing virological and immunological science being done, given the issues that Jess has highlighted and the challenges found with the Hep C cure. We need to start talking about how a Hep B cure could be implemented. Next slide, thanks. I've been interviewing people across the world working in Hep B in its form as a liver disease or as an infectious disease or as a cancer-causing virus, and also people working in hepatitis C or HIV, particularly those involved in the public health responses to these infections. Some of these people have Hep B, but my focus has been on people whose professional role intersects with the development and delivery of a Hep B cure. A key point with this is that it is only the basic scientists who are focused on a Hep B cure at the moment. For other stakeholders, the Hep B cure plays a marginal or limited role in their work. Given the time restraints, I'm only able to highlight a couple of ideas about the cure, and hopefully next year I'll make a far more comprehensive presentation. Next slide, Liz. I never thought I would ever include a slide like this in a presentation. It comes from a presentation from Peter Rebel of the Doyle Institute, a leading scientist working in Hep B cure development, and it illustrates the multiple targets of cure science. Peter talks of 2 types of a Hep B cure, a functional cure and a complete cure. A range of other definitions were reported by key stakeholders, but one thing was clear, that it would be a staggered process for development over time, and it would be also a staggered implementation amongst individuals. Key to its implementation will be the cost of any cure drugs. Advocating for resources for these drugs is essentially limited in countries where people with hepatitis B are discriminated against and marginalised, and this will affect implementation. While most Hep B cure science currently occurs in the laboratory, we know that science is often gendered, with men being the default population for clinical trials within Western countries. One ethical issue raised was that the populations most in need of a Hep B cure live in the Asia Pacific and African regions, and the cure needs to be trialled and made available within these populations. Next slide, please. The cure will be implemented in a marketplace where other cures already exist. While these 2 examples obviously lack credibility, They could make complete sense to a person when you consider that most people with Hep B are poorly diagnosed. They're not provided with accurate or accessible information about hepatitis B, and they're not linked into services providing clinical care. Most people with hepatitis B are born in countries where access to traditional health interventions are often easier, cheaper, and more accessible than Western medicine. In China, traditional medicine has an historical, political, and cultural significance, and these issues make the choice to use a scientific cure much more complex. Success in delivering the cure will not only relate to the drugs, but also in responding to the cultural and social context in which they're made available. Next slide, please, Liz, and this is the last one. A Hep B cure will not only be more complex than the hepatitis C cure, both scientifically, but also in its implementation, given the challenges so clearly articulated by Jess. But the impact will be profound, not only in reducing liver disease and cancer, but in the significant social impacts among individuals. As one informant noted, for people in countries where hepatitis B is transmitted across generations of families, the hepatitis B cure will change the fortune of whole families by reducing uncertainty and social marginalisation. Thank you for your attention. Thanks, Alisa.
Thank you, Jack, and thank you, Jess, for that really thought-provoking session. Jack, it's great to see you presenting slides that you would not normally. Obviously, the solution does lie in thinking outside the box, and it's lovely to see a cell diagram presented by Dr. Jack Wallace. For the next, we'll keep questions until the end. We've got one last final session. It's another combination presentation. I'd like to welcome Troy Combo, who's the Program Manager of the Aboriginal Health Plan from EC Australia, and Scott Monaghan, who's the CEO of the Bulgarr Medical Aboriginal Corporation, to present an integrated bloodborne virus STI model of care recently funded. Welcome, Troy and Scott.
Thank you for that, Alisa. Thank you for the introduction. And g'day to everyone, and happy World Hepatitis Day. I know we're a little bit early, but we're just here today to, I guess, officially launch a new partnership between Bulgarr Medical Aboriginal Corporation, EC Australia, and also ASHM. Next slide, please. As I said, there's 3 partners in this. The project is being led by Bulgarr, with EC Australia will be providing the technical support, and also ASHM's experience in, I guess, the adaptation and the development of training packages for workforce working in our sector. I'm going to hand over to Scott Monaghan. He's our the Chief Executive Officer of our partner service in Bulgarr, and he'll give a little bit of a background on the service, on the funding, and the local need of such a program to be implemented. So welcome to Scott.
Good afternoon, all, and thanks for the opportunity to present here today. Look, first and foremost, the Bulgarr was set up in the early 90s as a asbestos treatment service as a result of an asbestos mine in Barr-Yugal. So from the early 90s, I think we kicked off with 1 GP, a nurse, and a small dental service. We now have 5 separate sites that range from Tweed Heads in the north near the Queensland border to the Clarence Valley in the south, out to the west of the Tenterfield in the foothills, and we cover about 11 distinct Aboriginal communities in that area. We have about 18 GPs employed across that footprint, and over the period of time, the service has adapted with different funding models, with many different models of care across a lot of different services, and particularly with distinct communities having to adapt to the needs of those particular communities. But like all AMSs, with funding models, you're really providing a treatment service that's the theme of the Commonwealth Government or the particular government at the time. And whilst STI and bloodborne viruses were funded by the state government and was an integral part of our treatment program, probably as late back as 2010, that funding had changed, and it was really rolled into primary healthcare funding. But what that meant to the service was that a particular model of care that addressed STI and BBV treatment was almost became redundant, and the treatment or the needs of the patient at the time of the consultation really came to the fore. But thanks to the partnership with the Burnet Institute, ASHM, we look forward to going ahead in developing up a model of care that is a day-to-day process and becomes second nature to our clinicians, that's our health workers, our GPs in the clinics, and our nursing staff who are vital for providing those services. But it becomes second nature for what they do. We have acknowledged since 2010 that the testing rate in our services have dropped simply because it's not front and centre. And we're a community that has one of the largest jails in, I think, in the eastern states of New South Wales, with an 18-bed facility. Then we have one to the south in Kempsey, one on the top of the ranges at Glen Innes, and a second chance facility at Tabulum. So all of that adds to the need to have a sound and solid testing regime within the clinic. And we couldn't do that without the partnership and support, particularly the Burnet Institute, but and ASHM. And we look forward to going ahead and developing up a partnership that provides sound opportunity for community to be tested on a regular basis, rather than an ad hoc approach when someone presents unwell. Troy?
Just on mute, Troy. Had to be one of us.
Thank
you, Scott.
Next slide, please. So yeah, as Scott mentioned, the program will be co-designed and use an evidence-based BBV and STI program that will aim to increase the knowledge of the workforce and at the end of the day improve the prevention and treatment of services in an Aboriginal community controlled health setting in regional New South Wales. Phase one will be STI and BBV education, training, workforce development. That will be co-designed by ASHM with the local workforce to meet the needs of the local workforce, where we use existing training packages and adapt them to meet the services needs. And this will enhance capacity and competence of the workforce to manage and prevent STIs. And that will be done in year one. Also phase two, to build up for the testing campaign in phase three, will be rolled out over year one and year two. This will be the implementation of a CQA quality framework. And overall, we're looking to utilise better systems to improve local surveillance and monitoring, and at the end of the day, improve treatment outcomes and management of STIs and BBVs in the local Aboriginal community. We know by better systems utilisation for other diseases in Aboriginal community controlled primary healthcare settings that we can improve better outcomes, and a good example there is in regards to diabetes and diabetes cycles of care. Next slide, please. Phase three, which is the community testing campaign, utilising the rapid point of care testing and also coupled with the peer referral incentive program. We'll look to develop and train a local network of gene expert machine operators. We'll use testing campaigns to coincide with local events and community days, alongside whilst having testing campaigns within clinics and quality improvement cycles within the clinics as well. There'll be a peer referral incentive program. This will be to attend screening and then at key points across the care cascade. And the different care cascades to be determined will be derived from local data and where people are dropping off within the care cascade. So we're hoping to develop a template for this program and how this can be successfully implemented and integrated across the BBV STI awareness across other networks of Aboriginal community controlled health services. And we know that through tentative discussions with both NACCHO and VACCHO, there is an interest there to have this rolled out in Victoria. And we know that with the impending launch of the Victorian Aboriginal STI and BBV strategy, this could be quite timely to start considering some resourcing and financial resourcing to the sector to also bolster the efforts of the Aboriginal Community Controlled Health Service. Next slide, please. And thank you. Thank you very much. That's the end. Thanks.
Thank you, Troy and Scott. What a fantastic new partnership. It's very exciting to hear about what you've got in store for the next 2 years. So that does actually bring us to the end of the presentations. I'd like to invite now all the panelists and presenters to turn on their video. And I'm going to open the forum up to any questions from the participants or the audience. I can see we had one question from Wilson to Pearl in the Q&A feature, and I think Pearl has responded already, but I'd like to throw it open to any other questions from the audience today. And I might kick us off and then maybe throw to Margaret for a question before we see any in the chat function. Given what we've seen in terms of some of the fantastic outcomes that point of care testing can deliver for high prevalence populations and the MSIR and the partnership at St. Bees, I would like to invite Sione and other members from HR Vic, also Doc and perhaps Beck, to comment on how we might integrate point of care testing into health services and also out into community settings. Over to you first, Sione.
Oh, thank you. I think what I'd point to, I suppose, is the successful way that it's been integrated in Queensland at Quinn, which is a different organisation to Harm Reduction Victoria, but they're the user organisation in Queensland, and peer-based Harm Reduction WA in Perth. And the difference really between those organisations and ours is that they have a service delivery component that is quite robust, and so they've been able to do point of care testing through their services. I think that the way that we would need to incorporate and implement it in Victoria would be to, if we're talking about getting PathX involved, it would clearly be needing to partner with the clinical services that we're already partnering with. But I think the interesting, where I suppose, because the clear thing that we need is a really simplified process for people to be able to basically get their test and then be moved along to treatment as swiftly as possible. And I think a peer worker like Caro, which I was going to ask to comment on this as well, would be really important for keeping people occupied and for engaging them while waiting for the results from tests. But one of the interesting things that I sort of noticed at Quinn when I went up there to visit recently was that they were actually undertaking sort of outreach testing and then bringing the I forgot what they call, but bringing the tests back to base to their NSP to do the test there, and then they would go back out with the nurse back out to on outreach to the places that they engage people in the first instance a few hours later to deliver treatment, either a few hours later or the next day, sort of thing, to deliver the treatment as soon as possible. I think something along those lines would be the way to go, but I'm not sure if you've got any thoughts about it, Caro.
Are you talking about the Oroquick sticks, Sione, the licky sticks?
Well, that or the RNA ones, or the or you know the.
Alisa was talking about the RNA point of care stuff, and I think that it's something that would be really great to embark upon in primary care settings or in harm reduction settings in general. Yes, I'm just reading through the question. Engagement in case I was actually ready to answer the next question, but the question in the chat, which was about lived and living experience, but if we're not answering that one yet, I'll just shut up.
Caro, you're more than welcome to move on to that next question. Otherwise, do you want to make a comment just about how easily you would be able to integrate point of care testing into the work that you do?
Well, I just think it means that you can get people where they're at, which is what we're all about, isn't it? And to be able to say, hey, we have a point of care testing machine here. You're interested in doing a test today? it's all about what you can do right now with our people, because if they may not come back tomorrow. They may say, I'll come back in an hour and not come back because they get distracted in whatever activities their life is taking them on. But yeah, I think it would be really valuable to engaging people into treatment to have that in primary care settings or in places where our clients can access them.
Thanks, Caro.
Do you
want to make it? Yeah. Do you want to make a comment around the question from Gab Bennett around the difference or the distinction between lived experience and living experience?
Okay, so live ed experience. Okay, no, sorry. I'll start with living experience. The term, I think, grew out of the fact that live ed experience refers to somebody who has had lived ed experience in their past. However, people with living experience have experience in their current life. So with lived ed experience, you may have used drugs for the last time in 1995 and not used the drug since then. And therefore, to be able to engage in communities currently using drugs, you're not going to have current knowledge about what's going on in the communities and what's happening around the drug scene and all that sort of stuff. However, if you have current using experience, you kind of probably know what's going on sometime in the recent past and in the current day. And I guess that's the distinction.
Very clear. Thanks, Caro. So I can see you've got quite a few questions in the Q&A box. I'm going to pick one out. Whoops. We've got a question from Rachel. That's okay. And it's really a reflection question, I guess, thinking about some of the progress we've made in the hepatitis C space since treatment and cure have been available. And the question is really around whether we think the hepatitis C cure led to substantial changes in the perceptions of hepatitis C and engagement in care and stigma compared to, say, hepatitis C treatment. So I guess the distinction between getting rid of your infection, not just treating it, but curing yourself and being able to remove that stigma attached to it, really has led to valuable kind of uptake and engagement from the community. So I guess it could go to a few people. I might throw firstly to Jess and Jack to reflect on what this might mean for hepatitis B space first. Jess and Jack.
That's a great point. I might start and then hand to Jack. I guess with hepatitis B, there's two components. There's the stigma and discrimination component experienced by people living with hepatitis B, but there's also the worry of having hepatitis B and trying to avoid those nasty outcomes that can happen. And so with some cures and with current treatments for hepatitis B, they work very well for reducing the risk of those nasty outcomes, but they don't necessarily remove hepatitis B completely from the body. And so that there leaves lingering concerns and worry for people living with hepatitis B, and also perhaps has less of an impact on stigma and discrimination experienced by people living with hepatitis B, in contrast to complete cures where we may be able to fully eradicate the body of hepatitis B. We don't know what form cure will come in, but it is very relevant to the experience with hepatitis C. And I'm sure, Jack, you've probably had many people touch on this in their discussions with you through your work and research.
Yeah, thanks, Jess. Listen, one of the things for me, at a global level, only 10% of people with Hep B had been diagnosed. Fundamentally, there are issues in terms of access of the populations most affected by hepatitis B to the healthcare services. You know, I was kind of thinking around the stigma stuff is that, you know, when we treat hepatitis C as solely an issue of an infectious disease or, you know, we forget about the social marginalisation that occurs as a result of injecting drug use. So there's still that kind of conflict that happens. A cure is a paradigm shifting kind of thing, though. It absolutely changes how people perceive and relate to the infection. Yeah, sorry, I don't know how clear that was. Yeah, go.
So I was going to say, Alisa, I was going to just sort of comment here, and I recognise that this concept of I can be cured of hepatitis C can be very liberating, whilst taking into account you have to think of the stigma around injecting drug use. For hepatitis B, I'm beginning to think of it a little bit like with HIV, where I don't think we should ever underestimate the impact of HIV, of the U equals U story, of undetectable means untransmissible. And when I have discussions with patients still, and gay patients, my straight patients, always their greatest fear has been to pass on the infection to somebody they loved. And then their second thing is that they worry, or they want to make sure that they don't get sick themselves from the disease. But if I was to say what's the primary thing people focus on, is I don't want to pass this on to somebody. And I think that if hepatitis B, we can go, if you're on treatment, your likelihood of transmitting this to your unborn baby, your likelihood of transmitting this to your partner, all of these risks, when you have very low virus, are extremely low. We should never underestimate the comfort that that brings to somebody by that, as well as that we can vaccinate your loved ones. So to me, there's those things. So you can reduce risk of transmission, you can vaccinate loved ones, and then we can stop you from getting sick. So I think we can change the story, or I personally think we should change the story and how we talk about that. It's not, whilst we wait for a cure, as in the bigger sense of the word cure, I think we can have very positive conversations. And I look at the HIV story and go, we got a long way with that. And that gives people enormous comfort.
Can I also highlight the fact that Hep B is a family infection as well, transmitted intergenerationally through families. So unlike Hep C and HIV, it has more of a social impact or a familial impact rather than an individual impact, which I think is kind of one of the fundamental differences and really important.
Yeah, and so Jack, to me, I always think of it as if you can then vaccinate family, if you can impact to stop or reduce mother-to-child transmission, which in my view, for much of the world, means engaging with young women and who've got chronic infection in low and middle income countries and engaging them in the process, as well as in Australia as well. But to me, that's where I think it can be a very positive story if we really start to work hard there, as opposed to thinking we can start now and not wait for cure. We should start now.
Thanks, Margaret, Jack and Jess. Would anyone else like to respond to that question? Otherwise, we do have one sort of integrated question in the Q&A chat. So we've got a question from both Mark and Naylan. So Mark from Burnet and Naylan from LiverWell. And it really relates to point of care testing and how best to integrate testing into harm reduction settings or AOD settings. And Naylan wanted us to consider how it would roll out in rural locations. So Sione, it seems like you're back in the hot seat. Do you want to first comment from a harm reduction services perspective, and then we might throw to Thatcher, I think.
Really quickly, I think that well, Victoria doesn't have this as much as some of the other parts of the country, but time and space is still an issue for regional people, and being able to sort of access services in a timely way. And so I suppose when you're talking about outreach, and that it always becomes more tricky to on a cost benefit kind of analysis for an organisation anyway, when you're talking about doing outreach in regional areas. It always that's one of the challenges. I'm not saying we shouldn't do it, I just mean that's a clear challenge. And then the other part of it would be I guess it would depend on the circumstances, but I think feedback we get from people in regional areas anyway is that stigma discrimination seems to be amplified in regional areas. I'm not sure if that's specifically sort of related to point of care testing, but something to probably consider.
And Mark did mention sort of the potential to collaborate with implementation partners or health services. So rather than just implementing it yourself as a harm reduction service, but really in a partnership model, perhaps that's something Beck or Sione want to mention or comment on. Do you have plans for integrating point of care testing?
As far as harm reduction Victoria goes, like right now, the only viable model is partnership for sure, for a whole range of reasons. But I think that a number of the other peer organisations around the country have shown that they can run and deliver clinical services as well and do that really effectively. But I think you've always got to balance that with being a statewide organisation and trying to meet the needs of as many people as you can across the state. Beck, do you have any thoughts as well as a service provider?
Yeah, I think I'll just say that I think it's an excellent idea and an excellent, thing to work towards, and just comment on, you know, in our work about even just exploring phlebotomy and those sorts of things, just commenting on the workload that is required to have the systems up, you know, up to scratch, and you know, the workflow processes and all of that sort of stuff. Whilst the partnering and everything is really excellent, there is definitely a workload component and sort of a requirement to resource around those things. And if it's resourced well, I think there can be really amazing things done, you know, in this space and around, the use of peers doing this work. Absolutely. We really know that the trust and the relationship that's built immediately between living experience peers on site in a clinical setting is just way outweighs and is much quicker than the trust and relationship that can be built with a clinician. It's really quick, it's really thorough, and we have really good outcomes with people sort of returning to ask to speak to peers. So they're definitely an essential part of the future of this work.
Thanks so much, Beck. I'm going to hand over to Margaret to have some final comments before we close.
Thanks very much, Alisa. I think my job is simply to, number one, thank all of the speakers, for which I thought they were just, all of them, fabulous and interesting and enlightening and inspiring. So thank you all for your talks, but also for the work that's been going on behind those talks. So that I don't forget, I want to thank the people that did a lot of the work in organising this today and running it today, Alisa and Joe and Liz and Jack in the background. So thank you very much for that. My sort of wind up comments on when I listen to everybody is, you know, you'll all remember I quote various people all of the time, and I was just thinking, which one will I bring through today of my thoughts on this? And we have really big tasks ahead of us as we strive for the elimination of hepatitis B and hepatitis C by 2030. And people think of these things as difficult, or some people, I think that they're impossible. So Robert Kennedy quoted George Bernard Shaw when he said, "Some men see things as they are and ask why. I dream of things that never were and ask why not." So we can sort of do that one. But my preferred quote of that genre is the one that probably is the thing that I live by. When with Alice in Wonderland, when Alice said, "There's no use in trying, one can't believe impossible things." And the Queen of Hearts' response was, "I dare say you haven't had much practice. When I was your age, I would do it for half an hour every day. Why, sometimes I believed as many as 6 impossible things before breakfast." Now, I actually do think that we limit our way of thinking about what's possible by limiting our imagination, by limiting our goals, by limiting our aspirations, by thinking things are impossible. And to me, I always think of that quote as not really things being impossible, but us putting constraints on the possible. And so I would say thank you to everybody for your work and the effort and things that have been going on. And I had a whole list of things to comment on, but I'm just going to say it was all huge amounts of work have been done. And if we continue to maintain our energy, our enthusiasm, as well the hard work, because impossible things don't happen by chance. They happen because of persistence, by attitude, by pushing government, by government accepting being pushed, by funding. Just think if the 2 billionaires who put themselves up into space for all of 10 to 15 minutes had, instead of tried to race each other into space, had decided to race each other to eliminate a disease, and one had taken hepatitis B and one had taken hepatitis C and spent their money there, where we might be. So our challenge is to try and stay inspired, enthusiastic, and to perhaps inspire some very rich people to actually have the race in the right direction, which is to stop people dying from things they don't need to die from. So thank you all for coming today. Keep up the hard work. Keep working as partners, because that's how we'll get people, rather than shooting rockets into the air, shooting rockets into the direction of eliminating diseases. Thank you.
Thanks, everybody. Lovely to see everyone's faces, and look forward to joining a whole bunch of other World Hepatitis Day events throughout the week.
Yeah, happy World Hepatitis
Day.
Bye, everyone.